I'm Dr. Colenbrander. I live in San Francisco. For 25 years, I ran the low vision service there at California Pacific Medical Center. My clinical specialty is vision rehabilitation. That is dealing with the consequences rather than with the causes of vision loss. A question has been asked, what is the difference between testing with text, with sentences, or testing with single letters on a letter chart? We have to look at the stages of visual processing, and we can divide those into visual functions and functional vision. Visual functions describe how the eye functions, but functional vision describes how the person functions, and that is not always the same. There are three stages. First is the optical stage, then comes the retinal stage, then comes the neural stage. The optical stage depends on giving a clear optical image on the retina. Problems include refractive error and opacities, and we have known about that for centuries. Visual acuity is a good measure for those problems because foveal acuity predicts the acuity of the peripheral area around the fovea. Here you see that two pieces of the image are equally blurred. So the letter chart acuity on the right is a good measure of the image acuity on the left. You also see that letter chart acuity seems to be far more disrupted from a functional point of view than the recognition of a person or a face. This is the image that is called legal blindness in the USA, but you see that it's far from blindness. This is legal blindness for the World Health Organization and for most European countries, but it's still not blindness. Beyond the optical stage, we get the retinal stage, which translates the optical image into neural impulses. That creates problems when there are retinal diseases. We have only known much about retinal diseases since the invention of the ophthalmoscope, now only a century and a half ago. That is where we get scotoma interference. Here are two fundus images. Both patients have the same visual acuity of 20/70. But one eye can read much better than the other. That is because the eye on the left has a ring scotoma, as indicated by the dotted line, and the eye on the right does not. Here you see a word projected on a ring scotoma. The word wonderful, it's upside down because the image on the retina is upside down. That patient could see that central letter clearly, but he could not read the word as a whole. Here, visual acuity provides some information, but it's very incomplete because the letter acuity does not provide any information about the areas beyond where the letter is projected. So we need visual field information in the form of scotomata. The third stage is the neural stage, where the neural signals from the retina are processed First in the inner retina, then in the visual cortex, and finally in higher cortical centers that allow actual visual functioning. That is an area that has only recently started to catch our attention and is often overlooked. Traditional tests test only how the eye functions, and that is why we call ourselves eye doctors. But rehabilitation is interested in how the person functions, and that's why we do not talk about eye rehabilitation, but about vision rehabilitation. Visual functioning is dependent on visual inputs from the eye, no doubt, but it also involves cognitive processing. When you use the SK read and compare it to the MN read, the reading speed on the MN read is 3 times higher than on the SK read because it's helped by cognitive recognition of what is a meaningful test. It also involves motor output, be it in manipulation tasks, be it in writing, be it in reading, where you need to move your eyes from one word to the other. According to research at an English university, it doesn't matter in what order the letters in a word are. The only important thing is that first and last letter are at the right place. Many English-speaking people will read this paragraph easily and are only halfway through when they recognize how messed up it is. I give you this only as an example of how big that cognitive component is.